This recording will go over Chapter 44 of ATI. The title is Antibiotics Affecting the Bacterial Cell Wall. Antibiotics that affect the cell wall are bactericidal. This group of antibiotics includes penicillins, cephalosporins, carbapenems, and monobactams. This lecture will focus on penicillins, seen here abbreviated PCN, cephalosporins, carbapenems, as well as vancomycin, which is a glycopeptide antibiotic. So there are different types of medications that fall under the classification of penicillin. When you see a medication that ends in the suffix cillin, C-I-L-L-I-N, that's your clue that you're dealing with a penicillin. The two specific types of penicillin you need to be familiar with are penicillin G potassium, which is a narrow spectrum medication used for IM or IV use, and amoxicillin, a broad spectrum medication used for PO use. And you need to know which one's broad spectrum and which one is narrow spectrum. So here's a question for you. If I had an infection and the results from my CNS, my culture and sensitivity, haven't come back yet, would the provider be more likely to prescribe a narrow spectrum antibiotic or a broad spectrum antibiotic? So if you said broad spectrum, that would be correct, because broad spectrums are sensitive to a wide variety of infections, whereas narrow spectrum are sensitive to only a few types of bacteria. So if something hasn't been identified, you will frequently see a broad spectrum antibiotic prescribed for that. So how do penicillins work? Penicillins destroy bacteria by weakening the bacterial cell wall. They are considered a beta-lactam antibiotic. Your textbook lists the therapeutic uses for penicillins. You can look over that. I'm not going to test you and ask you if you know which specific infection is treated with a penicillin. In terms of complications, we're going to be monitoring for allergies and anaphylaxis. So allergies, normally you're thinking of itchy skin, hives. It can progress to respiratory issues. And that's basically what anaphylaxis is, that allergic reaction has progressed to the point where it's now severe, life-threatening, and the patient is at risk for respiratory arrest. In terms of what we want to do as nurses, we want to always ask the patients if they have any prior allergies. We want to observe for an allergic reaction for 30 minutes following parenteral administration of penicillin. We want to make sure that we teach our patients to wear allergy identification bracelets. And we also want to know about cross-sensitivity. So a patient who's allergic to one penicillin is going to be considered allergic to all penicillin. So if your patient says, I'm allergic to penicillin, and you're holding amoxicillin in your hand, are you going to give that to them? The correct answer to that one is no. We'd want to call the provider to say, this patient has a penicillin allergy and amoxicillin's been ordered. Did you want to replace it with something else? In addition to not wanting to give penicillin, any type of penicillin, to a patient who has a penicillin allergy, we also don't want to administer penicillin to a patient who has an allergy to a different classification that's considered a cross-sensitivity. So patients or clients with a history of allergic reactions to penicillin, cephalosporins, or imipenem are likely allergic to the other two. So if I have a cephalosporin allergy, I likely could have a penicillin allergy, as well as an allergy to the classification of imipenem. Now, in this case, your patient lists a penicillin allergy, the doctor prescribes a cephalosporin. This one, they might want to know how severe the allergy to penicillin is, because again, when we're saying the patient's allergic to penicillin, we're totally eliminating that as an option to treat the patient. So sometimes you might see them prescribed one of these cross sensitivities, but in general, you would want to question a prescription for a cephalosporin or imipenem for a patient who has a penicillin allergy. You'd want to ask the provider about that. Renal impairment. We want to monitor kidney function. So how do we monitor kidney function in our patients? So we have it right here, monitor labs and INO. So we want to see what the output is, what the kidney output is, how much output there is in comparison to intake. And we know that in general, the rule of thumb is how much urine, how many milliliters of urine should the patient have per hour. Hopefully you're thinking 30 mLs of urine per hour is what we're looking for. That's our minimum. Monitor labs. Which lab values are we watching for renal or kidney function? Hopefully you're saying the serum creatinine as well as BUN, right? Glomerular filtration rate. Those are lab values that tell us about kidney function, and you want to know those normal lab values. High doses of penicillin G potassium can cause hyperkalemia, which can then cause dysrhythmias. So patients receiving high doses of penicillin G potassium, we want to monitor cardiac status and electrolyte levels. Penicillin in the same IV solution as aminoglycosides inactivates the aminoglycoside. So nursing action, we can't mix aminoglycosides and penicillins in the same IV solution or use the same tubing because the penicillin inactivates the aminoglycoside. Probenecid delays the excretion of penicillin. So what would be my concern if I was taking a medication, probenecid, that delayed the excretion of penicillin? Right? My same concern is if my kidneys aren't functioning well, I'd worry about an increase in the concentration of the penicillin, possible accumulation and toxicity. Penicillin nursing considerations. We want to instruct the client to report any findings of an allergic response, such as dyspnea, a skin rash, itching, and hives. Again, we want to catch any allergic reaction before it progresses to the point of causing respiratory issues. We want to give IM injections cautiously to avoid injecting into a nerve or artery. We want to teach our patients to take penicillin V, amoxicillin, or any amoxicillin combination drugs with meals. And all other penicillins we want them to take with 8 ounces of water 1 hour before or 2 hours after a meal. If you hear take on an empty stomach, that would be 1 hour before or 2 hours after a meal. We want to advise the client to complete the entire course of therapy, even if symptoms have resolved and they're feeling better. This is something you'll hear over and over again when talking about these antimicrobials. It's important for patient teaching. Patients start to feel better, they stop taking the medication. That can lead to resistance types of infections. So we want to make sure that our patients take the complete entire course of prescribed therapy. We also want to advise clients to use additional contraceptive methods when taking penicillins because penicillins can cause a decrease in effectiveness of contraceptive methods. So this slide has some additional information that's not in the HI textbook, and it's about beta-lactamase inhibitors. So penicillin and cephalosporins, which we're about to talk about, are known as beta-lactam antibiotics. And what bacteria can do is it can produce different types of enzymes, including beta-lactamase. And you know it's an enzyme because it ends in that ASE. And that beta-lactamase that the bacteria produces can inactivate penicillin and other beta-lactam antibiotics, such as cephalosporin. So we're giving the patient an antibiotic, penicillin, to kill the bacteria, but the bacteria is producing an enzyme that inactivates the medication. So what you may see sometimes is a antibiotic that's combined with a beta-lactamase inhibitor, enzyme inhibitor. So we'll have that penicillin that works well along with the medication that prevents that enzyme beta-lactamase from inactivating the antibiotic. So broad spectrum antibiotics such as amoxicillin can be combined with beta-lactamase enzyme inhibitors, making the antibiotic effective and extending its antimicrobial effects. And here are just some FYI, the three beta-lactamase inhibitors that you may see combined with another medication. So the next classification we're going to talk about are cephalosporins, and the prototype you need to know is cephalexin. And you can recognize a lot of medications from this classifications because they start with Ceph, either CEF or CEPH. That's the prefix that you'll see on these medications. How do cephalosporins work? Just like penicillins, they destroy bacterial cell walls, causing destruction of microorganisms. Cephalosporins are broad-spectrum bactericidal medications with a high therapeutic index that treat a wide variety of infections. Here's another FYI slide that I've put in. Sometimes you hear about medications that have different generations. So first generation, second generation, third generation, fourth generation. The higher the number, the more recent the medication was developed. And basically, these newer medications that are developed for some sort of reason. So each subsequent generation of cephalosporin is more likely to reach cerebrospinal fluid, is less susceptible to destruction by beta-lactamase, and is more effective against gram-negative microorganisms and anaerobes. Cephalosporin complications. If the patient has an allergy, hypersensitivity, anaphylaxis, or possible cross-sensitivity to penicillin, right? If you're allergic to penicillin, we're worried that you're allergic to cephalosporins. We want to question clients carefully about a history of allergy to a penicillin or another cephalosporin and notify the provider if they do claim to have an allergy to penicillin or another cephalosporin. Again, it may be possible that the provider will still want them to have a cephalosporin even if they have a penicillin, a mild penicillin allergy. But again, we still always want to alert the provider about the penicillin allergy. If indications of allergy appear, such as urticaria, rash, hypotension, or dyspnea, we want to stop the cephalosporin immediately and notify the provider. You want to know that certain types of cephalosporins can lead to bleeding tendencies. And if a patient is taking a cephalosporin that leads to bleeding tendency, we want to monitor labs that show clotting times such as prothrombin and INR. And we want to prepare to administer parenteral vitamin K, which helps with clotting if the patient does have a problem with bleeding. We want to observe IV sites for thrombophlebitis. We want to rotate injection sites and administer as a dilute intermittent infusion or slowly over 3 to 5 minutes in a dilute solution for bolus dosing. If the patient has renal insufficiency or problem with their kidneys, we want to give the medication at a lower dosage to prevent accumulation to toxic levels. So sometimes you'll see the provider orders a certain dose of a medication, such as a cephalosporin, and the pharmacy fills it a different way, and you call the pharmacy like, what's going on? And they'll say, it's the kidney function. They have to lower the dose because the kidneys aren't working well. Cephalosporins are mainly eliminated by the kidneys. Pain with IM injections. Administer IM injections deep into a large muscle mass. Educate client about the possibility of pain at the injection site prior to administration. And finally, antibiotic-associated pseudomembranous colitis. So that colitis again, inflammation of the colon. So what might you see in your patient? Diarrhea. So observe for diarrhea, notify the provider if present, stop the medication. There's a risk for developing C. diff by consuming broad-spectrum antibiotics. So that's what we're watching for. The patient has C. diff, associate C. diff with colitis, severe diarrhea. In terms of contraindications and precautions, do not give cephalosporins to clients who have a history of severe allergic reaction to either penicillins or cephalosporins. Use cautiously in clients who have renal impairment or bleeding tendencies. A disulfiram reaction, which is an intolerance to alcohol, can occur if certain cephalosporins are taken with alcohol. So we want to be looking up the medications if your patient's prescribed a cephalosporin and advise them not to consume alcohol if they are associated with a disulfiram reaction. Also, probenecid delays renal excretion, so we want to watch patients' INO, kidney values, kidney lab values. Calcium and ceftriaxone interact, so do not administer those together. And then in terms of nursing administration, advise the client to take the entire course of therapy, even if their symptoms have resolved. Oral cephalosporin should be taken with food, and oral cephalosporin suspensions should be stored in a refrigerator.